Chapter 35, Geriatrics and Geriatric Emergencies. Yesterday, when we went over lifespan development in Chapter 7, we saw sort of how things start and begin to ramp themselves up and how kids sort of develop over time and things get better and turn more normal. Now we're going to look at the other side of that coin, and we're going to get into geriatric medicine and start talking about how, as we age, instead of becoming more functional and better, things become less functional and worse. One of the things that's always a bit confounding with geriatric patients is the fact that they, as they age, become more susceptible to different medical problems. They have different chronic illnesses. They have different medications that they take every day. They have chronic conditions that can become acute conditions and sort of present us with actual emergent type signs and symptoms. And there's just a lot going on and a lot of working parts as we start talking about working with the elderly. Everything's interconnected. I think we've done a pretty good job of putting that together so far. All of the body systems, all of the body processes are really sort of interwoven, and one needs to work well in order for another to work well. And as we get older, some of that starts to go away. We teach a class about geriatric medicine called GEMS. It's something you can take as a continuing education credits for your recertification in a couple of years. And they really look at the whole when we talk about how we assess a geriatric patient. Now, that doesn't mean, we get wrapped up in looking at their environment and looking at this and looking at that if my patient is acutely ill. But we have to understand that geriatric patients can be way more involved. They may present completely atypically, meaning, you get called out for general malaise. General malaise is a fancy $10 medical term for I don't feel well. And you could show up and your patient could have complete and total non-specific complaints. They may show you next to nothing as far as signs go. They may have next to nothing that makes any sense as far as symptoms go. And they're having a heart attack, or they're having some sort of respiratory compromise, or they're having maybe even a stroke. As things start to age and wear out, their neurologic function starts to go down a little bit. So they may not perceive pain quite the same way that someone of a younger age would. So we have to keep in mind that sometimes our geriatric patients are a bit trickier to figure out than someone of younger age. When we talk about doing their environmental assessment, we're really looking at their surroundings, because one of the things that we can look at as emergency providers, and some of the best sort of medicine we can offer these folks, is how to keep them the healthiest in their home, because most people, that's where they want to stay. Doing an environmental assessment and looking around at the patient's surroundings, because they don't always need to go to the emergency room. Sometimes we get the 911 call for, granny who slipped on a place rug, or tripped over a cord, or just wasn't able to get up out of their chair and needed some help. Okay, cool, no problem. We can fix that. We'll get called out, we'll help them up. Non-injured, conscious alert oriented ×4, can't force them to go to the emergency room, so they stay home. But if we happen to leave whatever it was that they tripped over in their environment still on the floor as a tripping hazard, we have done them a complete and total disservice. So helping them out a little bit on the back end and kind of having a teachable moment where we don't allow them to sort of have to go through further injury, which will just serve to make any of their conditions worse, is something we've gotten a whole lot more in the habit of as time has gone on. Another thing the environmental assessment sort of looks at with an elderly patient is Is their house 175 degrees in the summer, or is it wintertime and you can see your breath inside? That tells me that maybe this elderly person has some issue with being able to afford some of the normal things like electricity or home heating oil. And, getting sort of a view behind the curtain and trying to help figure out what we can do to best provide for this patient if they can't provide for themselves. Now, I'm not saying fill their oil tank, but looking around at the things that are going on for this patient. Someday I'm going to be old, and I hope somebody takes that good care of me. As far as social assessment goes, what do you think that sort of points us towards? What are we talking about when we're doing a social assessment for our geriatric patient?
Are they like alone all day?
Yeah, are they alone all the time? Do they have anybody coming to visit them? Do they have anybody to assist them with the activities of daily living? Or are they pretty much solo all day, every day, and maybe need a little bit more community support? There is just a lot that goes into getting older. And as we're going to see in the upcoming few slides, none of it really is altogether that easy. As we age, everything breaks down a little and everything just becomes more difficult. This lecture is not, one that we're going to walk away from bright and sunshiny and happy about the feeling of getting older, because we are going to talk at length here about how the body changes and the different effects on the body system. And age-related changes happen a lot earlier than you would imagine. When do you think you start having some age-related changes in the physiology of your body? Somebody just give me a number, throw something out there.
40.
30.
Start losing your eyesight.
Whoever said 30 actually hit the nail right on the head. Things begin to change way earlier than I ever thought they did. 30 was, yikes, at this point, almost 10 years ago. And I didn't notice anything, but there are some things that begin to happen as we even reach just 30 years old. Aging itself is not a disease. Aging is not going to automatically make you someone who has hypertension, make you automatically someone who has, high cholesterol. Aging just makes the body more vulnerable to disease and injury. It's not something that is constantly all the time pathologic. I mean, people are living to 100, 105 years old, no problem, not a care in the world. But there are still some things that are going to go on. Elderly people, I've already said, have, chronic medical conditions, which is things that they get treated for by a doctor. They're generally fairly well controlled with medicine, or they can be victim of any type of acute type emergency you can imagine, or their chronic condition, for one reason or another, can become an acute problem. This is a lot of the times something we see around like different holidays. Easter jumps to mind. We have people who have congestive heart failure or bad kidneys who aren't really good at filtering out all the excess things, and they wind up fluid overloaded from going out and having a nice salty ham dinner. Their congestive heart failure is chronic. Their renal failure or renal insufficiency is chronic. But when something irritates that system particularly, their chronic condition becomes acute, and their acute condition turns into an absolute emergency. So what are some things that you think change in the cardiovascular system over time with our elderly patients?
The way their heart pumps, their circulatory.
Yeah, so the way their heart pumps, for sure. The heart actually will decrease in cardiac output, and the heart, as it ages, really just kind of doesn't pump quite as well. Some of the valves in the heart can actually break down, those one-way valves that prevent blood from regurgitating between the ventricles and the atria or between the pulmonary capillary beds and the ventricles and the aorta and all of that, they'll start to develop some calcium deposits that will actually break down and wear away and deteriorate those valves. So now, on top of decreased ability to pump, we have blood that doesn't really stay going all the time in the direction that it's supposed to. And if you add to that things like a history of heart attacks from before or hypertension as a general rule, the heart has to try and overcome more, and it really doesn't always have the ability to compensate and meet the demand. When we talk about the actual vascular system, we'll talk about some different problems with the buildup of plaque. So our arteriosclerosis will have hardening of the arteries, so the atherosclerosis. We just have some stenosis in those valves. So on top of those calcium deposits and things breaking down, they just actually will begin to narrow and blood doesn't flow quite as well. Cardiac hypertrophy is generally a side effect of uncontrolled hypertension or hypertension for a really long time. It means the actual ventricle walls, left ventricles specifically, excuse me, will begin to thicken. And when that ventricle wall thickens, it actually intrudes into the space of the ventricle that's supposed to be filled with blood. So it makes everything, stroke volume, cardiac output, go down. It makes it really less efficient. And some of those compensatory mechanisms that this elderly person may rely on in an acute situation can't raise to the challenge anymore. What is this orthostatic hypotension? Anybody recognize that?
I've heard something about, well, ortho is bone. Is it the breakdown of bone?
So that's going to be more like osteoarthritis and things of that nature. I like the way you started to break down the word, because you're right. Ortho generally means having to do with bone. Orthostatic hypotension is going to be when our patient, think of your elderly patient now, think of some of the things we've talked about already. When we have a shock patient, what position do we want them in? How are we going to transport our shock patient?
Sitting upright.
Sitting upright.
Lying flat.
Lying flat. Someone who's got orthostatic hypotension will have significant changes in their systolic blood pressure between laying flat, sitting up, sitting down, and standing up. So sometimes our elderly patient, because those baroreceptors inside their body aren't really working the way that they're supposed to, and we have all of that athero and arteriosclerosis making it more difficult for the arteries to expand and contract the way that they're supposed to. When they go from a seated position to a standing position too fast, they get woozy and have a syncopal, and down goes grandma. That's orthostatic hypotension. We'll have a significant drop in their systolic blood pressure just by the mere act of standing up and spreading your blood out a little bit more, and making it, have to pump against gravity. And some of the breakdown over time doesn't allow for that to happen quite as rapidly as the patient is used to or would like it to. With our respiratory system, we have a whole bunch of changes. We talked about a couple of them yesterday, and we'll talk about them a little bit more today. We have a decrease in size and strength of the muscles used for respiration. So tell me something that tells you right now. The muscles themselves have gotten smaller and they're a little bit weaker. Ventilation is a mechanical act, right? Contract muscles to get gas in. We have to relax muscles to get gas out. So what would changing in the muscles' ability mean to their respiratory rate, rhythm, and quality?
Everything's gonna be like slower.
Slower, it's going to actually be a little bit more effort because smaller and fewer muscles accomplishing the same amount of work. The smooth muscle fibers that are around all of our bronchioles are actually going to decrease in number. We may have a decreased resistance in the patient's airway, but they may also have a difficult time getting gas out because of the change in size of the airway and the difficulty in actually maintaining and changing the diameter of those bronchioles. Going to have some diminished resistance to infection. Really, it takes very, very little amount of aspirated contents into the lungs to cause a significant or fatal infection in an elderly patient. Add to that all of those same muscles we've already talked about and made our peace with the fact that they're not quite as up to snuff. Decrease their ability to cough. The muscles are weaker. They have a decreased reflex to cough, which means they may have a harder time eliminating things from their lungs, and they'll actually just sit down there and cause all sorts of problems and all sorts of infection. And if anybody still thinks they can't wait to get old, the rest of this doesn't get any better. Because we're going to have changes in our neurological function as well. The brain itself actually gets smaller. Our elderly people will have a decreased ability to perceive hunger and thirst. It's all based on neurological things. They have decreased sensory perceptions. Does anybody have an elderly family member that has either cut or burned or banged their arm or something and didn't even realize that they were bleeding or had a giant bruise until somebody pointed it out to them?
Yes.
That's because some of these actual sensory nerves are beginning to sort of go by the wayside a little bit. Now we add to that the fact that really our eyes are part of our neurological system as well. And you'll have changes in your visions. There'll be cataracts and glaucoma and macular degeneration, retinal detachment, possibly even blindness. Cataracts are the clouding of the lens. Glaucoma just makes it difficult for the transmission of information for the eyeball. Macular degeneration can lead to just a black spot in the middle of their vision. Retinal detachment means the tissue in the back of the eye just comes apart, really comes off. And they can be victims of just everyday neuropathy, just breakdown of any of the nerves, generally starting at the periphery of their body. So the further out from the central nervous system they get, those nerve fibers and those nerve endings just don't pick things up as well as they used to. Move on into our GI system. They have a decreased ability to actually perceive hunger and thirst. They have a reduction in their sense of taste and smell. There may be some breakdown in the structures of their mouth, so teeth and jaw and gums will actually start to be a little bit painful. They won't produce as much saliva. They have a decrease in the smooth muscle contractions of their GI tract, that peristalsis that moves food through. So on top of having a difficult time actually perceiving being hungry, all of these things just sort of support the fact that they're going to feel more full all the time. Maybe peristalsis is slow down. They wind up with some like chronic and constant GI upset. They have a difficult time moving their bowels. And actually the physical act of eating becomes way, way less fun. They don't get the same joy of actually nourishing themselves. And it can actually lead to malnutrition and really sort of self-neglect. Our endocrine system is another one that turns into a rather large-scale problem. Our endocrine system will have a decrease in the amount of hormones that are produced. We may have a difficult time because of that. regulating the fluid in our body. So our body doesn't produce as much hormone to help us actually generate urine and get rid of some of this excess fluid. And to boot, what's one of the big things that our endocrine system is responsible for? What's one of the big, most important things that our endocrine system does for us?
Well, other than regulate, well, like diabetes is a disease of the endocrine system, so
Yeah, that was
I
the
feel like
big
that's
one we
important.
talked about with endo problems. And since this patient is aging and things are beginning to break down, the endocrine system is no different. You may actually sort of begin to outlive the life expectancy of your pancreas, and your pancreas won't produce as much insulin. Or maybe your body just doesn't respond to it and use it quite as appropriately as it used to. And we'll have type 2 diabetes beginning to develop as someone gets older, and their blood sugar levels will just begin to rise. And if anybody knows anything about old people, I'll tell you one thing for sure. Boy, howdy, can they be stubborn, right? Try telling somebody who's lived 80, 90 years that they can't have an ice cream every night like they used to because, because of the sugar. It's hard to get them to change what their general everyday routine is, especially because they don't always see the after side of all of this. They don't always, think about how much damage things like just some simple elevated blood sugar and how some real minor changes to their lifestyle is going to improve their quality of life because, well, they've lived for 90 years doing life the way they do it. And sometimes getting them to actually change and do the things necessary for them to be healthier can be a difficult feat. When we get into the musculoskeletal system, well, the more things change, the more things stay the same. Our elderly patients are going to be victims a lot of times to osteoporosis, osteoarthritis. Now, osteoporosis is the sort of breakdown of the bones. They'll have loss of minerals in the bones. Their bones become much more brittle. A lot of the times they call them like thinning. They really get to the point where it takes not a whole bunch of force for an elderly patient to wind up with some pretty significant fractures. Hips and pelvis is one of the big ones. A simple fall that you or I would get up from, dust ourselves off, and be on about our merry way can be life altering up to and including the point of life ending for an elderly patient based on just the fact that their bones aren't quite as rugged as they used to be. Kyphosis is change in the curvature of the spine. If you look at the pictures in your book of your spine, it's sort of like S-shaped, right? Kyphosis is seen as some of these musculoskeletal changes take place and it changes. Those intervertebral discs, all of the muscles and ligaments and tendons that hold us in that upright position begin to wear out and break down a little bit, and it moves. And that kyphosis is just sort of arching in opposite and different and strange directions of our patient's spine. We'll have decreased joint flexibility and range of motion. This is one of the things you've probably heard me say on more than one occasion about how backboards aren't people-shaped and people aren't backboard-shaped. You have an elderly patient with kyphosis from just the fact that they're old, and you'll see that, you go to lay them flat on the backboard and their head's still sticking up, or they have these great big giant gaps on the backboard. And are they adequately spinally immobilized at that point if we have all this extra space and all this ability for them to move around even just physiologically?
No.
No, so we would have to actually pad all of those voids. And a lot of times, backboarding, as much of it was sort of for far too long the gold standard of what we did. it wasn't really helpful to these patients. We caused a lot of tissue breakdown. We caused a lot of actual more damage instead of less. And then we also figured out that, backboards don't really do what we thought they did in the first place. Backboarding is still something that you'll need to know how to do. Don't expect it to be something that you're going to do a whole lot of once you pass next week's practical examination. Our renal system.
To pat down someone with kyphosis, though, do you have to take them out of the, like once you strap them down, I know you can't do anything because then you can possibly move their spinal cord. Do we have to take them out and then put padding down and then put them back in?
No, this is not something that would be a surprise to you. You would look at somebody, and I mean, the kyphosis, a lot of the times, especially when we're talking about somebody who's got it and who has all of these musculoskeletal problems, you would recognize right off the bat, like there is absolutely a 0% probability that this person's going to lay flat when I put them on the board. And you can put things in like towels and sheets and blankets to sort of eat up that space a little bit and hold the patient as best as you can. We have breakdown in our renal system. Kidneys become smaller. All of the bits of our kidneys that actually are responsible for filtration, the nephrons, will actually reduce in number. And if we don't have as many of the filtering bits and pieces left in our kidneys that are functioning, we'll have a hard time creating urine. We'll have a hard time filtering out our blood appropriately. We'll have a hard time maintaining that acid-base balance that's so important for regular cellular metabolism to take place. Electrolytes, which are hugely important in the conduction of nerve impulses, will be sort of out of whack. We'll wind up with generally too many electrolytes, which can cause cardiac dysrhythmias. So all of these things, as they begin to break down, they begin to break other things further up the line. The skin, if anybody's ever seen a skin tear on an elderly relative, this harkens right back to the deterioration of nerve fibers and the ability to sense and perceive pain. And then you start thinking about the way that their skin structure changes. The subcutaneous layer, all of that cushioning, all of that padding that we have as younger people starts to break down and lessen and go away. The muscles will actually start to atrophy and get smaller, and our muscular tissue is less able to provide another layer of shock absorption. And our skin itself begins to thin. The dermis and the epidermis actually start to detach from one another. That's why our elderly patients look like they have all those wrinkly, sort of gangly skin. This is a big problem for things like, abrasions. Even just a small trip to the carpet can cause a pretty significant amount of damage to the integumentary system. It can cause pretty significant damage to the musculoskeletal system. And each of these things being more susceptible to injury is going to now further the fact that my patient could have sustained a significant trauma from something that looks simple. And then now let's talk about hormones, right? So we'll go right back to the endocrine system as well. Our endocrine system, not really up to function as much anymore either. So less epinephrine gets released. And those baroreceptors and all of those things that their cardiac and respiratory system is supposed to do to overcome this traumatic event, they no longer have the ability to rise to the occasion. Now, if we talk in terms of some of their chronic conditions, things like high blood pressure. As you know, high blood pressure is a huge problem. Everywhere, everyone, doesn't even matter. You don't even have old or young, it doesn't make any difference. But elderly people have generally been dealing with it for longer. They'll have more physiologic changes. they'll have a much more extensive medication list. And some of the medications that they can be prescribed to maintain their blood pressure on a chronic basis at a normal level will actually rob the body's ability to compensate for shock. We could show up from a pretty simple trip and fall and find an elderly patient who is already in decompensated shock because their body doesn't actually have the ability to do that anymore. So now let's talk some assessment. With all of this stuff that I've talked about going on, tell me some things that you think you might hear from an elderly patient or a geriatric patient who is having chest pain, our ACS patient. What do you think they're going to tell you? What do you think you might hear? What do you think you might see? What do you might find? Do you expect for them to have that, textbook crushing substernal 10 out of 10 chest pain radiating to the left jaw and arm? Or do you think it's going to be something different? Yes, it's going to be something different. I see from Jessica in the chat. What are they going to tell us that's different? What's going to be not like the others?
Maybe the quality of that pain, or the way like the onset of it.
Okay, so maybe it doesn't have that radiating pain. Maybe it's perceived a little different. They don't feel it the same way. Would you be surprised at the first words on the bullet points down there being silent heart attack? You may have an elderly person who has absolutely no complaint at all other than, I just don't feel really well. I've been tired. Fatigue is a big one. Dizziness is a big one. General weakness is a big one. Does any of that jump right out at you and say, hey, this patient is probably having a myocardial infarction? Because I'll tell you, as far as I'm concerned, it doesn't. So how would we get to the bottom of this? How would we know that we were supposed to give this patient aspirin or nitroglycerin, or what we were supposed to?
If he has
Is that where
medication already.
I had Jessica and Lenny in there at the same time.
Sorry. If they already have like nitrogen, or like if they already have a past history of heart meds.
Perfect. So they give you this laundry list of cardiac medicines. Nitroglycerin happens to be one of them. So we know that they have a history of at least chest pain, right? Angina pectoris. And as we start chipping away at that and we start asking them more questions and we start asking them, hey, have you ever had a heart attack before? And then we watch light dawn on Marblehead. Yeah, come to think of it, I have. I had one a few years back, and you know what? This feels pretty similar. Well, ding, 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 ding. From there on out, as long as they meet the rest of our protocol, as far as I'm concerned, and as far as the state and as far as general medical knowledge and advice is concerned, this is going to be an acute coronary patient until somebody proves otherwise. Because they just told me in their history, yep, have had a heart attack before. I've been prescribed nitroglycerin for chest pain. And this feels like my last heart attack. The complaints are non-specific. Nowhere, anywhere, ever in there did they say to you anything about pain in the chest. They gave you this very general list of complaints. And by asking, like Jessica said in the chat room, that sample history and digging a little bit, not just taking no for an answer, and asking those open-ended questions, we get down to it. Because a lot of the times, our chief complaint for an elderly patient that's having a cardiac event is going to generally be either respiratory, indigestion, or a shoulder ache, like aching between their shoulders. None of that jumps out to me and says, boy, I think this patient's having the big one. But I would dig a little and I would ask more questions, and I would, especially if I had nitroglycerin in their medicine list, I would pick at that a little bit and try and figure out, is this respiratory in nature? Is this GI in nature? Is this a reproducible shoulder pain from gardening or a fall that they had earlier in the week? Or is this likely to push me towards this patient is actually having a cardiac event, an acute coronary syndrome, and never really giving me the textbook answer? Our congestive heart failure patient, we talked about congestive heart failure during the cardiology lecture. The heart is not pumping quite as effectively. This next bullet point is sort of just a fancy way of how I told you that blood backs up to where it came from. Our right-sided heart failure patient is likely to have those great big distended jugular veins. Our left-sided heart failure patient is likely to have some crackles and respiratory distress. These changes are just because the pump is not pumping effectively and causing a backup in the old circulatory system. Characteristic CHF patient is going to have dependent edema. So any areas that are below the level of the heart, think your feet and your ankles, and even in the buttocks, and even starting to progress up into the abdomen as this patient gets sicker, they are likely to have fluid everywhere. So you can actually take your thumb and do what's called, you'll find pitting edema. You take your thumb and you press it into the top of a patient with CHF's foot, and you'll leave a dimple right in the top of their foot that doesn't go away right away. A lot of times, especially if this happens to them when they're laying flat, they'll complain of difficulty breathing at night. They wake up in the middle of the night because they can't breathe. We may have chest pain. They're going to be anxious generally. And our emergency care for this is going to be respiratory in nature a lot of the times. We're going to sit this patient upright because gravity is going to help them breathe better. We'll place them on oxygen. We'll transport them. If they have all of these complaints and they say anything to you about chest pain and they have a prescription for nitroglycerin, guess what? You would be well within your right to give it because they said chest pain. And they would probably even get a little bit better. But you could only give their nitro for chest pain. They have to tell you that their chest hurts. They have to fit the protocol. One of the other things that might be beneficial to this patient, what do you think it might be? It's an oxygen delivery device.
CPAP.
CPAP, indeed. We're going to put this patient on CPAP because CPAP is going to force those alveoli back open, and it's going to make them more available for gas exchange. It's going to hopefully start to hold some of that fluid at bay. It doesn't push it out anywhere. We don't have that kind of pressure. What we're trying to do is just make most of the lower portions of their airway as available as we can. Our congestive heart failure patient and our CPAP patient generally present with some form of pulmonary edema. You'll hear those crackling, you'll hear those adventitious lung sounds, and it's going to cause some respiratory distress. That pulmonary edema is just that. It is swelling and fluid and pressure built up inside of the lungs that is making it more difficult for them to breathe. We talked about their increased susceptibility to disease causes. Pneumonia is one of the big causes of septic shock in our elderly patient. It's another thing that's likely to cause some pretty significant dyspnea. It could be from something like aspiration. all of their muscles begin to break down. Their epiglottis begins to become a little bit lazy, and food and other things that aren't meant to get inside their lungs can wind up inside their lungs, and they will go down there and cause a pretty significant pneumonia. They will have problems with their immunological system actually being able to fight off some of these diseases, and they don't get better at quite as quickly and as vigorously as they used to. And we will see someone who maybe is even being treated for pneumonia that actually will go into septic shock in pretty short order and wind up very, very ill. Our stroke or our cerebrovascular accident patient, we already know what this woman's doing right here. What is the name of the test that this patient is performing for us right now? So it's the arm test, you're right, but what is that? What's that a piece of?
A fast test?
Yeah, the FAST test. Face, arm, speech, and time. We're trying to figure out the likelihood that this patient is having a stroke in front of us, having some form of cerebrovascular accident. Now, we don't have the ability to diagnose either stroke or TIA in the field, so we are going to base our assessment and our treatment off what we find. If your patient doesn't successfully pass that FAST test, if your patient has a history of hypertension and high cholesterol and maybe atrial fibrillation, which can cause blood clots to be shot off all over the place and cause all sorts of havoc in our patient's vascular system. Here we're specifically speaking about the cerebrovascular system. Our patient, if they flunk one portion of that FAST test or our BFAST, because we want to talk about balance and eye trouble as well, one piece of that means it's likely that they're having a cerebrovascular accident. We're not going to hang around and try and split hairs to figure out, is this a TIA or is this an actual stroke? Because a TIA generally are precursors to stroke. They used to be called mini strokes, but they have the same exact signs and symptoms, and they generally reverse themselves within 24 hours. So we're not going to hang out and wait and see if Nana gets better. We're going to transport her and let her be evaluated by a CAT scan, because once they get images, they'll know whether there's an occlusion, whether there's a hemorrhage, whether there's anything that they can do to treat it, or if there's nothing, they'll monitor for a little while, diagnose her with a TIA, and everybody gets to go home happy. Since we have problems with our kidneys being able to adequately eliminate things, our liver actually also shrinks in size and ability. And elderly people generally are on a pretty decent amount of medications as you know, we start evaluating their history. It is possible for them to be actually holding on to and not eliminating some of their daily medicines, which can actually turn into a toxic event. They can actually have complete and total overdose on their medicines that they are taking as prescribed the way that they're meant to. One of the things we want to look at when we start evaluating for drug toxicity is, do you have any new medicines? Has anything changed? Because all of these drugs that they're prescribed have the ability to get inside and cause all sorts of different interactions with each other. And we can have changes to their mental status, syncopal episodes, respiratory arrests, altered mental status, just anything and everything, depending on what it is that they've either A, mistakenly taken too much of, or had a recent change in their medication that has now caused this problem for them. And our care for this patient is really going to be symptom based. If our patient is altered, we're obviously going to check a sugar because it doesn't rule something and it'll rule it out. But we want to monitor our patient's airway, breathing, and circulation, because depending what the medicine was is going to depend on the symptoms we see and the signs they report, is going to depend what we need to do to support the functions that are keeping them alive. If you add in some of the other pieces that we've talked about, trouble with their vision, some neurological changes, maybe some mental status changes in general, and maybe they accidentally took their daytime meds and their nighttime meds at different times or at the same time because, well, I grabbed the wrong planner, but then I just took the next ones anyway. So it's very simple to see how some of this stuff does become a bit of an issue, and that really can be part of that whole environmental assessment and that social assessment we talked about. Some of the mental status changes are pathologic. Some of our mental status changes are just a product of getting older. Do not assume, though, that just because your patient is getting a little bit on in years that the cheese is slipping off their cracker and they can't understand you and they can't hear you and they can't see you. Go into it with open eyes. Go into it trying to figure out, as I talk to this person, assess their mental status, assess their visual acuity, see if they can see you, see if they can't hear you, and try to figure out, is all of these things normal? Dementia is something that can be caused by medication. Dementia is something that we're seeing a whole awful lot with brain trauma patients or patients who eventually get diagnosed with Alzheimer's. Dementia is a chronic condition that can really lead to a loss of short-term memory and decline in your patient's ability to maintain their intellect and changes in their judgment and abstract thought. So anything that's different is going to be a problem. Dementia, though, chronic and progressive. Delirium is sudden onset change in mental status. People generally that have dementia and families of people that have dementia know and understand that this patient has dementia. Someone who is in a delirium state is someone who the flip of a switch just all of a sudden started to have this altered mental status that caused pretty much all of the same things as dementia, but it was sudden, it was right away. When we're evaluating our elderly folks after a traumatic event or in a situation where we may see some shock beginning to present itself, altered mental status can happen from any one of a number of things. We've talked about that, and it's not going to change as you get older. Their reflexes may be a little bit slower, their eyesight may not be quite as good, their hearing might not be quite as good, and everything becomes a little more fragile. They lose muscle tone. Traumas that to you and I can't stress this enough, traumas that we would get up and be like, wow, that stinks, limp away and be perfectly fine a few minutes later, can absolutely lead to death of your elderly patient. I had a neighbor years and years ago. Her mom had a simple fall in the backyard, transported right away, so it's not like she laid in the backyard for hours or days. Simple, nothing really big. May have been a fracture, I'm not even sure. That patient, who was living on their own, died a month later, having never been home after that fall. And we wouldn't have even had so much more than a scuff mark on us. Falls are the number one They cause more than half of all accidental deaths in your elderly patient. And generally speaking, they result in some sort of head injury. One of the big things we're on the lookout for with a trauma in an elderly patient, especially with a head strike, is do they routinely take blood thinners? If your patient has atrial fibrillation or has valve stenosis, they're probably taking some sort of blood thinner. If your patient has had a heart attack in the past, they may be prescribed some sort of blood thinner, something that actually promotes their ability to bleed when they have a traumatic event. Beta blockers, so a lot of our hypertension meds. ACE inhibitors, so more of our hypertension meds. A lot of things that these people are going to be prescribed are going to turn simple trauma into really terrible, horrible, no good, very bad day, quick, fast, and in a hurry. See, we all did the 51A stuff. So now let's talk about how we assess. Oops, wrong button. Something in the chat room. All right, so I said, open mind, open eyes. Approach every single patient, no matter what, with concern and consideration. Yeah, well, no kidding. But this whole ageism thing is probably a bit over the top. It's not really ageism. You just look at someone and they're elderly, and through really most people's interaction with an elderly person, you assume that they're probably a little hard of hearing. Maybe they have some vision troubles. It's hard not to do, but until they tell you they can't hear you, just talk in a normal tone, talk in a normal rate, and they'll stop you. Believe me, old people pull no punches. If you're doing something that aggravates them or they can't understand you, you will know that they can't understand you. One thing to definitely be on the lookout with this group is our advanced directives. So look for your DNRs and your most forms and all of that stuff. And really just go into this thinking that you are assessing any other person. I generally introduce myself to every single patient. I shake hands, and it gives me skin color, temperature, condition. It gives me their perfusion status most of the time. I can get a pulse, rate, rhythm, and quality. And it gives me a chance to figure out what my patient wants to be called, because elderly people are big on respect. If this patient says that my name is Mr. Johnson, you can bet for the remainder of my assessment until he tells me I can call him Bill, his name is Mr. Johnson. And it really wins sort of the wins the friendly battle with these folks, because sometimes they are set in their ways and they're not really a big fan of having to go to the hospital, and they really can be a bit difficult from a patient management standpoint. But they also will understand that if I've called him Mr. Johnson, sir, something like that, then it gets me to the point where, even though I'm a stranger to this gentleman, he understands that I probably have his best interests in mind, and I'm really looking out for him as a person. Our scene size up? Well, still nothing changes. Scene safety, BSI. I am going to try and figure out the environmental temperature, because that'll tell me, is this patient adequately caring for themselves? Sure, I do need to know that. Have they been in this 120-degree, living room all day, and could that be part of why they had a syncopal? Could that have led to whatever the trauma was that we got called out for? Could that just be why they called with a medical complaint saying that they were dizzy? Well, it's 120 degrees in here. They don't generally, as a general rule, elderly people drink enough fluid, because it will cause them to have to go to the bathroom all the time. Because I take my water pill religiously, All right, cool. So you take Lasix and you don't like to drink because it makes you have to pee, but it is 120 degrees in the shade in here, and you are dry and hot to the touch and not sweating. And I start connecting the dots and I start asking more questions. And I realize that there's not an air conditioner to be found anywhere. And, 2 plus 2 equals 4. I can start making some decisions right here based on my scene size up. But I'm always going to start where I always start. Assessing their mental status, getting my general impression, looking for life-threatening hemorrhage, assessing and treating problems with airway, breathing, and circulation, skin color, temperature, and condition, and deciding stable versus unstable. Treat as a high priority patient. I'm going to bring them to the closest appropriate facility with an ALS intercepting route. And then guess what? We meander on our way into our secondary assessment. You're still going to get your OPQ-RST. You're still going to get your sample history. You're still going to evaluate your patient's baseline vital signs. If you have a patient who happens to be blind or happens to be deaf, it is difficult to get in the habit of tailoring your assessment to that. But we have to. Diminished sight's not really that big of a problem. If you introduce yourself to your patient as you're approaching, you'll know very quickly whether they're blind or not, because a blind person generally doesn't change when you speak to them. Their eyes just sort of stay focused. They'll answer you, but it doesn't do them any good to look at you, so that they don't generally even bother. It's something that their body has just become accustomed to. Deafness or difficulty hearing, on the other hand, they could read lips. They may have difficult time picking up higher pitches. So rather than speaking louder to someone who is hard of hearing, lower your voice. Change the frequency of your voice. Make it a little deeper as you're speaking to them, and they may actually be able to hear that. If your patient has hearing aids or something like that and they're not in, but they know where they are, send somebody to go get them for you. It's going to make your day and your life way easier. The same thing goes for things like glasses or walking canes. These are things that we have to start sort of thinking about bringing with us for this patient, because they might need them to actually be able to assist in their care at the emergency room. All right, we're going to take a break because it's 9:30. Then we'll talk about our emergency medical care, and we'll talk about some of the new bits and pieces that are available to us as emergency service providers to actually provide much better going forward care for some of our geriatric patients, because it's not always about the right now. Some of what we are actually doing in the field already today is providing much better care for them. And we'll talk about that in pretty good detail. All right, folks, we are back. So as you see here from what I left up on the screen, our treatment priorities do not change a whole bunch just based on the fact that our patient may be of an advanced age. It's all relative. We need to maintain their ABCs. We need to insert an airway as indicated. We need to assess and be prepared for having to assist with their ventilations. We need to establish and provide oxygen. We're going to position them as best we can, or however their current problem indicates we should. We're going to transport. We're going to reassess. And all of the same protocol type rules that we've been following right along remain in place. Your chest pain patient, aspirin and nitro is indicated. Your anaphylaxis patient, well, if they're over the age of 65, we call medical control. Don't be surprised if, by some stretch of the imagination, you wind up having to Narcan an elderly person. The very first time I ever heard of Narcan being delivered was in a nursing home. And it was because the patient had, a month's worth of fentanyl patches on them because they weren't taking them off. So mistakes happen. These are things that are possibilities. So all the same rules, just keep following them. That's why we do things the way that we do. And I mentioned that we changed a little bit over time. Healthcare, especially emergency medical healthcare, used to be very reactionary. It used to be when something happened, then we fixed it. Now, as far as the treatment of patients who maybe are of an advanced age or maybe do have some chronic medical concerns, we have something called mobile integrated healthcare. Right now, all over the state of Massachusetts, Cataldo has paramedics showing up to people's houses to do home visits, to do house calls like doctors used to do. And they do all sorts of things from med reconciliation and making sure the patient is taking their medications appropriately to actually putting them on the phone with a doctor. They will actually start IVs and give antibiotics. They run lab work right there in that patient's home. This is the wave of the future. This is something that has actually been opened up to BLS level providers. With some time and some experience and some increased education, you could be going out to do the exact same thing. What is this meant to do? Why do we do this?
To keep our older population safe from maybe COVID or any communicable diseases. I don't know if I said.
You said it right, and that is absolutely part of it. That's what has helped it take off the way that it has. But
The
really,
best treatment is prevention.
right. An ounce of prevention over a pound of cure. If we can keep them healthy, we can keep them out of the hospital, we can keep them in their homes. So these are of the utmost benefit to some of these more at-risk populations. Add to that now with all of this COVID stuff that's been going on for the last year and a half, and we can keep them away from the things that are making them sick. There's telephone health care. We send medics out to do in-home follow-up care. We do a large amount of patient education. We will actually go and try and keep people from the emergency room. There's programs called ER at home, where we go and provide the same type of evaluation that this patient would get in the emergency room, speak to a medical control physician, and actually are able to treat them in their house. This is way better than sending people to the emergency room. It limits the amount of draw on the emergency room staff. It limits the amount of expense of sending people over and over and over to the emergency room and having nothing change. Think of how old and tired it must get bringing the same patient with the same complaint and the same concern to the emergency room, and then 6 hours later, going and showing up and bringing them home, knowing that you'll probably be back at that residence within that same shift to do the same trip over and over again, because this care wasn't available, and now it is. And it's not always just about healthcare either. Some of it is actually getting these patients set up with some social services and getting them the right sort of follow-up care on top of our little emergency medical service piece of it. You know, things like Meals on Wheels, things like getting them set up with elder services in their city or town, so that maybe their house doesn't have to be 140 degrees in the summer and 25 below in the winter. We go in and we actually assess their living environment, and we figure out ways to make it safer, ways to make it better. We can actually help them navigate their aftercare with either their PCP or some other follow-up specialty physicians, things like that. This is a multifaceted approach at trying to keep people out of the emergency room and keep people at home. Because one of the things we've learned over time is just being well, being free from disease, doesn't really account for the actual well-being of our patient. There's plenty of people who may not have any real large-scale, long-standing medical concerns, but their lives are miserable as they get older. And believe it or not, some of this mobile integrated healthcare, some of this stuff that's coming down the pipe that we're doing right now, actually improves that in one way, shape, or form. It helps with their activities of daily living. It helps them maintain their independence. It helps them stay at home or stay on their own and independent for as long as they can. It takes a village, because really, it takes referral, it takes buy-in from everyone who makes these kind of decisions. OEMS has to sign off on it. They are impossible. The hospitals have to buy into these programs, and everybody has to see that there is some benefit to them, because that's how you get people to sign on to things that are new. It can't just be beneficial to the end user. It can't just be beneficial to that patient, because everybody says, all right, well, if it's good for them, but it's not good for us, what do we care? That's nonsense. What it has to be is good for all parties involved. We can limit some of this frequent ER trips, which realistically, in the grand scheme of things, do nothing but waste resources. We can help actually improve the quality of life of congestive heart failure patients. We can prevent falls before they ever happen, so that some of those life-changing, life-altering, life-ending injuries don't occur. We have actually been able to limit the 30-day readmission of people in some of these programs, which means they get discharged from the hospital, and within 30 days, they are generally, depending on how sick they are, right back in the hospital. We've been able to fix that. And realistically speaking, this is way better than responding to, you know, an elderly patient or a chronically ill patient when they are too sick for us to really do any bit of good for them. At the end of the day, most of our care for an elderly patient is the same as it is for anyone else. But advocating for our patient and making sure that we are doing all the right things for them, especially as you get on in age, is realistically where we earn our keep with this, because we're not going to fix their chronic problems. It's just not a thing. If their doctor can't fix their chronic problems, we're not going to fix it in their living room. Whether we're there as a mobile integrated health team or whether we're there as part of an ambulance crew that's meant to bring them to the emergency room. But knowing that there's other options out there, and knowing that there are more things that can be done for this patient other than bringing them to the emergency room, bringing them back again, bring them to the emergency room, bring them back again, 2, 3, 4 times in a shift. And then, all right, well, you didn't get called out to Mr. Johnson's house for the first time in a month. And then you don't get called for a month because he was in the hospital and then in rehab. And then Mr. Johnson gets discharged from rehab because he gets better or his insurance runs out. And all right, well, we're back to Mr. Johnson's house 2, 3, 4 times in a shift, 10, 11, 12 times in a week. This is so much more beneficial for the patient, so much more beneficial for the system in general and you as EMS providers, because going to the same call at the same place at the same time every single day really gets old. I understand that it gets old. There isn't much we could do about it previously, but now there's other options and there's better options. Yeah, do we have to bring Mr. Johnson to the emergency room? Sure do. But we can break the cycle and get some of that sorted out a whole lot better than just bringing them back and forth and back and forth and back and forth and waiting for them to disappear for a month. Anybody have any questions as far as geriatrics go? Did anybody finish that lecture and go, boy, oh boy, I can't wait to get older?
No.
Yeah, me neither. All right, so here we go. Now we are getting into patients with special challenges. And that mobile integrated healthcare chat was a good segue into this, because you don't just have to be old to be at home and have a very involved chronic medical history. There are people today at home living with just untold amounts of chronic type medical diseases and winding up on mechanical ventilators and IV pumps and gastric tubes to feed them and all sorts of other hugely complicated, very involved devices. The take-home point from this lecture is, don't be distracted by the equipment, because it's not your job to run any of it. You need to focus on your patient. You will actually, once you receive your certification and start working on an ambulance, as a BLS provider, be able to transport a patient on a mechanical vent. That means they are breathing on a machine. Have we learned anything about running or operating or setting or changing a mechanical ventilator? Do you think in the next few days of lecture, I'm going to be able to teach you anything about a mechanical ventilator? We've never talked about starting an IV or running an IV pump. We've never talked about NG tubes or feeding tubes or any of that stuff. And we're not going to. Because if you are transporting a patient on some device that you don't recognize and you aren't trained to use, you don't use it. If the family is going to come with you and they have been brought up to speed on how this equipment runs and how this equipment works, they are Johnny on the spot for maintaining and fixing anything that goes wrong with that equipment. Your job is to focus on the patient. Now, there's a lot that goes into the training of family and patients about how their ventilator works and what they need to do for their ventilator and what they need to do for this and what they need to do for that. Listen to them. But if it's outside of your scope of practice, don't have anything to do with it. It's possible that some of this equipment fails or doesn't work, or your patient isn't getting whatever benefit they were meant to from it. Your job is the signs and symptoms. Your job is the chief complaint. Your job is not to go fiddling around with the vent or fiddling around with the IV pump, trying to figure out how to fix that problem and get them some benefit from this piece of equipment that they're attached to at home. When we talk about patients with special challenges, we talk a little bit here about disability. So we'll get into physical, developmental, intellectual, This is where we talk a little bit about the blind and deaf and how to best care for those patients. Developmental disability is just insufficient development of the brain resulting in some level of dysfunction or impairment. It could have something to do with hearing or vision impairments. It could have an intellectual component, which means that their intellect and social abilities don't always adapt and develop and form at the normal rate. And any of these can have large differing amounts of degree. You gotta go into these patients, any type of patient who has some form of challenging type of problem, as a clean slate. You go in and you start your assessment. Your assessment is going to tell you how you need to proceed. It's not our job to figure out what their disability happens to be. It's not our job to figure out what sort of special challenge is presenting itself to us. Our job is to care for the chief complaint and the patient and the signs and symptoms and respond accordingly. So we work our way through. If our patient is slightly impaired, they may be slow to understand the things that we're explaining to them. They may have a limited vocabulary, and we may have to ratchet things down a little bit. Even if we would like to be in a hurry, being in a hurry is not going to be any good to anyone, because we start ramping the situation up and trying to be fast and trying to be slick and trying to get out of there, and it just winds up slowing us down. Now, how do you think we get a lot of better information and a lot of better patient interaction when our patients are challenging in nature? What do you think the best thing you could possibly ever do is?
Like listen to them.
Listen to them for sure. You can never go wrong listening to your patient.
Be patient.
Be patient for sure. I like it. Let the family help. You are not going to be an expert in this patient's care. The people that are responsible for their care on the general every day, much like with children, are the ones that are going to know this patient in and out. So let them explain to you how this is supposed to work. Now, I know that's probably a foreign concept, and I will tell you it is difficult, because you get on scene and you're at an emergency and you're the one responsible for this patient's medical well-being, and that alpha side of your personality kicks right into gear, and you want to be the one making decisions, calling the shots, and figuring all this out. In these types of situations, that's just not going to work. One of the next things we're going to talk about is the autism spectrum disorders. These are another group of disabilities that have just a wide swath. They have any one of a number of different challenges that they present. It could be behavioral, it could not. There could be repetitive motor functions and activities, so they could have, almost like sort of in the OCD realm, you have to flick a light switch 3 times before you can enter or leave a room. They may be nonverbal. They may be very sensitive or not sensitive at all to any type of sensory stimulation. So we follow the lead of the parents. We let the parents introduce us as a friend or a partner in all of this, and do everything one step at a time, very focused. Because one of the things that they'll tell you about this autism spectrum disorders is anything that interrupts this patient's general routine is likely to be problematic. So we need to try and massage this patient's routine as little as possible, so that we can actually get some assessment done and figure out what may or may not be wrong with this patient. And there's so much benefit to speaking with someone who has history and experience in dealing with this patient, and that is absolutely going to be whoever the caregiver is. I am all too happy to take a back seat when it comes to patients who are, from a management standpoint, not easy to sort of get through to. You know, you have to be willing to take your time, you have to be willing to slow down, and you have to be willing to sort of take the edge off all of the things that are going on. You know, you may want to run to the emergency room. Priority one, lights and sirens with your patient who has an autism spectrum disorder. And then you have to think about the fact that, am I doing the best good for this patient because they have light and sound sensitivity? What do you think that's likely to turn into on your transport from their home to the emergency room if you have the sirens screaming the whole time?
Not so good.
Not so good indeed. Next, we'll move on and talk about Down syndrome. Down syndrome is a genetic chromosomal problem. It can have mild to severe impairments. There can be some sort of physical abnormalities that you can view on assessment. One of the big things that we talk about with our patients who have Down syndrome is they have increased risk of medical complications. 40% of them have heart conditions, hearing or vision problems. We don't have to worry about this next bullet point when we talk about intubation, but ventilating them with a mask can be challenging. Using a jaw thrust can be challenging. Their cervical vertebrae are less,
Their C-spine is different too. I have a
yeah,
son with Down syndrome. You have to be very careful with them.
yeah.
With C-spine. Matter of
The-
fact, by the age of 11, they are mandatory, have to have a C-spine special x-ray, because the doctors need to make sure that they can actually grow like an extra vertebrae into their skull that can damage like that whole area there. So by
So
the time
around the
by the
brainstem.
time, yeah. So yeah, you just gotta be careful.
Yeah, no, I didn't know that. I know stability is a big thing. So again,
Hmm.
I think like what would be insignificant trauma, generally speaking, if we think there is some C-spine involvement, we definitely need to be on the lookout for some C-spine compromise and maybe some problems with circulation, sensation, and motor function, because 15% of patients with Down syndrome do have, I had never even heard of what Jessica was just telling us about, but they do have instability in their cervical spine, just in general.
Hmm.
Jessica, please enlighten me if there's anything you would like to add to this.
Nothing. Well, like for my son had, that's one of the reasons why I wanted to come into this, because we were in ambulances like all the time. He was born with congestive. He had an ASD and a VSD. He has chronic airway and lung disease. He had a trach for 14 years. So there was a lot of suctioning. He had a G tube for 14 years. So all that stuff. At the end of the day, they're very lovable. They don't like to get their routines mixed up. The parents, one of the big things is that we know all about them. So when you don't let us tell you or show you, it gets a little bit frustrating, because sometimes people do, they're like, oh, this is my job, I know what I'm doing. And I'd be like, no, this is my kid, I know what I'm doing.
Generally,
Um,
people that
Lots of
act like that
medicine.
have no clue what they're doing too, by the way, just saying.
Yeah, lots of medications, lots of everything. But yeah. I mean, he's great now. I'll bring him in. You guys will love him. A lot of things have gone on with him. He was a part of Chronicle, because he was one of the first adolescents with Down syndrome in the state of Massachusetts to undergo a research that would help, because a lot of kids and adults with Down syndrome have sleep apnea. because of their low muscle tone and their big trunks and whatnot, what have you. So they implanted this thing inside my son in order to take out his trach so he can breathe. There's a lot of mechanics that go into it. Point blank and being, I basically have to turn him on with a remote at night so he can sleep. And then end of the day, he's been fine. He was able to graduate high school and do a whole bunch of other things.
So that is, Jesus, we could stop this lecture right now. That is the take home. I normally, at some point in this lecture, I'll probably bring it up. We get to a point where we start talking about cerebral palsy. And just sort of to try and drive home the point that, you know, problems come in many different forms and shapes and sizes, and they run the absolute gambit of, you know, just people in general. Just, you know, having a disability doesn't make anybody any different from you or I. They just process information sometimes differently than we do, or respond to information differently than we do. And Jessica was absolutely right. Don't be one of those providers who's like, yeah, this is my job, I know what I'm doing. Because I guarantee you that this interaction will turn into a complete and utter catastrophe right in front of your very eyes if you take that kind of attitude. I do know what I'm doing, and if I showed up at Jessica's house, I would keep my mouth shut and my eyes open until.
Cataldo has always been good. I had a problem with like Fallon one time on a transfer coming home with him. But as far as Cataldo, every time they would come to my house, they were always very nice, giving Jesse high fives, you know, and then
Yeah,
asking me, all right, mom, what do you want to do? Where do you want to go? So,
and realistically speaking, that is the absolute most appropriate and best way that you can handle a situation that is not part of your everyday. Sure, if I show up to a motor vehicle collision or a cardiac arrest or a patient who's got, you know, any one of a number of other, you know, milk and cookie type medical problem, things that are right in our wheelhouse. Absolutely. I'm the guy in charge. I do know what I'm doing. But when I show up to something that is outside of my wheelhouse, where the person who lives, eats, sleeps with this person every single day is telling me, hey, this is what you need to do in order to make this go well, I'm going to shut my mouth and do exactly what they told me, because I want this to go well. Having this turn into a screaming, absolute nightmare of a call, what does that do? What good does that do me? Just because I got to be in charge? Ugh, forget it. Next, we're moving on to brain injury. Brain injuries are more and more common all the time now. We've realized that, you know, concussions weren't the nothing that we thought they were years ago, and we start seeing things like CTE and people having huge personality and behavioral changes as their brain injury either doesn't get better or continues to get worse. Talk with your patient, figure out what is normal by talking with the family. You know, a lot of this is really just taking your cues from someone who knows, because much of this does have to do with perception and the way things are perceived and the way the brain processes information. So if we can involve someone whose judgment this patient trusts, someone whose judgment this patient knows is in their best interest, someone who deals with them day in and day out, and be seen in that same light, in that same realm, whether it's a TBI patient, whether it's an autism patient, whether it's someone with Down syndrome, or someone who is blind like the next bit that we're going to talk about here. It really does go miles in trying to figure out and trying to make this all go as smoothly as possible. Because these aren't the easy calls. These aren't the just, yep, pick them up, dust them off, bring them to the ER calls. When we talk in terms of blindness, we hit on that a little bit when we talk to the elderly in changes in people's vision. But now we're talking about people who are just blind generally from birth. Some patients are completely and totally blind. Some patients can see shadows. Some patients can see light versus dark or shape. Some patients have problems with their central vision or their peripheral vision, so they can't see the sides or they can't see the middle. It can be increasingly difficult to recognize whether or not your patient is blind, which is why your patient interaction is very important. Make yourself known as you enter, and you can start figuring out what might be some of your patient's current limitations. You know, introduce yourself. If they have something that helps them see, like a pair of glasses or anything and everything that you could possibly imagine, get that for them. I can't stress enough about the vulnerability that these people feel and how they can be very easily disoriented. I have a story that I don't share on recording, so we can talk about it later. I had someone who was mean to one of my patients who happened to be blind, and we all had a bad day. Describe things to them. Let them know what is going on, because they don't have the ability to see. It's one of the 5 senses. It's one of the big ones that allows them to be able to interact with the outside world.
Tommy, one of the questions, as I think it was, that asked if they had a seeing eye dog, can we bring it?
To be honest with you, I don't know the answer to that question.
Or say it was like a PTSD dog.
Well, what you'll see is when you ask questions that don't have a clear-cut answer, no matter how many EMTs or paramedics or even people at the Office of Emergency Medical Services that you ask, if you ask 10 people, you'll get 10 opinions. I'll try to track down the answer to that question for you, but I do not know what the actual sort of line in the sand happens to be.
I just didn't know if there was anything like legal, because like I know like people have dog allergy and stuff. Like obviously we have to clean the trucks anyways, because I know like if you separate a dog, someone from their PTS dog, it can just cause an old episode just because their dog's not there. That's not security, and they might need it. But then in the hospital, like you can't have dogs, but then service dogs. So I didn't know.
And the other side of that is, while this patient's in the hospital, who's taking care of the dog? The one thing that is an ambulance service we run up against is there's no actual way to secure that dog in the ambulance in the thought that there could be a crash. Now, am I going to sit here and tell you that I don't think that there's wiggle room in all of that? No, I think anytime that a rule that I don't agree with is in place, that I can figure out a way to get around it. But am I saying that if I were you, I would hang my hat on that? No, I am not. So I will try to get the actual answer to that question for you, and we'll see what we can do. Much like with our visually impaired patients, our hearing impaired patients, it can range. There could be slight hearing loss to complete and total deafness. Some of the clues that a person could be hearing impaired, well, if you are speaking to someone and they do not acknowledge the fact that there are words leaving your human at all, they probably can't hear you. Start by changing pitch, changing tone, and if they have hearing aids, get them for them. Face the patient as you talk to them. A lot of people who are deaf can read lips. If they are reading your lips, you do not need to exaggerate your lip movements. All you need to do is look them in the face from about 18 inches away and speak to them normally. To them, it's like reading a book. People who are good at reading lips can just read the words as they're coming out and make sense of what you're saying. Yelling at someone who is deaf is not going to make them hear you better. It is all about pitch sometimes if they have any hearing at all. I love this slide, and every single time I say I want to delete it because it drives me nuts, because they say American Sign Language may be useful. Then they show you these 3 signs. And you know what they don't do? They don't tell you or me what any one of the 3 of them mean. If your patient cannot communicate with you, whether it's because they're deaf and they only speak sign language, or it's because they speak a different language than you, don't pretend that you speak their language unless you are prepared to communicate with them. I learned French in high school. I'm not very good at it. I am not going to speak French to someone who is only of French speaking. I learned how to speak Spanish once upon a time. I am very rusty, and now, again, not very good at it. I'm probably not going to start peppering questions to someone who only speaks Spanish, because you know what's going to happen next? They're going to answer me, and I'm not going to have any idea what they said. So there's ways around all of this. There's a language line that we can call, and you can get a translator on the phone right there in your patient's house. There are probably, I don't want to say definitely because I haven't been in communications in a long time, but on that language line, there probably is the availability to video conference someone who speaks American Sign Language to communicate with your patient who happens to be deaf. So don't, use your little bit of armchair American Sign Language that we learned in this, because God only knows what you're saying. I have no idea. I've never had the thought to even look, but she is clearly saying something in the American Sign Language, and I haven't got a clue what it is. Ta-da! There's your American Sign Language.
I took sign language. She's saying sick. The first one's sick. The last one's help. And the middle one, I don't know what she's doing there.
I think the middle one is how you feeling, because my son has sign language too. So when you like roll that and you roll it, that means feeling.
Yeah, they're not even showing you it properly, but yeah, it's the first one's sick, the last one's help, and the middle one is just she's pointing at her stomach, I would just assume, but the other
Hmm.
two she's just saying sick and help.
They're labeled somewhere in the textbook. I don't know where, but those 3 are in the textbook labeled.
But there again brings me right back to my point that they're going to answer you with something. And you've already set the precedent that you understand American Sign Language. You're in the weeds, because I would be able to say sick and help. Sure, great. I can point to my head, no problem. I can make a fist and put it over my hand and say help, great. I'm not any help from that point on, though.
One thing that's easy to learn at some point, like the only thing that you guys should, like, if you ever want to know, is just learn the alphabet. The alphabet's the easiest thing, and then you can say your name through that. But it's sign language. I've only learned basic, and I've forgotten like 95% of it.
Yeah, speaking a language that isn't your natural language. And Jessica, you bring up a good point. Pen and paper is always probably a really good idea in the beginning. But speaking a language that is not your native language is difficult if you don't use it all the time. So, maintaining the ability to communicate in American Sign Language will really probably require you to use it more often than you would imagine. All right, let's see. That was it. I think we all got the point of that lecture, which is good. So we got an hour, and you guys don't have to be here for even longer than that. So head on over to EMS testing and get yourself some, hang on one second, we got a link. Miniature horses, huh? So it looks in here like Boston EMS has something in place to authorize them to treat service to take service animals in the ambulance to the emergency room with their patient, which is good because that's the decision that I would make, to be honest with you. But I'm going to find on OEMS what the OEMS actual ruling on that is, and I assume that it's probably somewhat the same. So from here on out, head on over to EMS testing. I want to see some more adaptive tests. If you looked at any of the stuff that I sent out by email yesterday, some of those videos about figuring out a national registry question, I sent out a bunch of stuff on Quizlet for each of the 5 grading categories. If you start chipping away and picking at some of that stuff and trying to figure out what it is that the national registry is actually getting at, it's a human chess game. They're probing your ability to think critically. So some of the stuff might not make any sense. Some of the stuff might not even be valid as to what they are asking you. You have to pick out the important stuff. You have to get rid of the garbage. If you know some of the hallmark signs and symptoms that were attached to that email that I sent you, you're in good shape. The other real bonus thing you can do for yourself is know the flow of your trauma and your medical assessment patient, because they will ask you questions that say, you have done this, this, and this, and this. What would you do next? And it is directly correlated to what is on those assessment sheets. So let's see some more EMS testing. I'll take a look at the grades again, and we will see how you guys are doing. Other than that, I'll see everybody at 1 o'clock.
Thank you.
No problem.